that brings us to the rules of osteotomy. Okay, so let us look at this one and take it that the proximal axis, that is the femur, is normal, right. So if we do our planning, first of all is mechanical axis deviation. There is medial mechanical axis deviation. So we will draw the proximal axis by extending the femoral axis. So that's the proximal axis, alright. And distal axis I can draw 90 degrees to the tibial plateau. That's also the mid diaphyseal line of the distal fragment. So now my cora, so the cora is now right up over there. And you know, in a child, this is the epiphysis you see, but there is another epiphysis which comes down almost up to here. That is the anterior tongue where the quadriceps ligamentum patelli attaches, right. So now if you have to do a correction for this, where will you do the correction? If you can do the correction right at the cora, what kind of correction would you like to do? Opening wedge or closing wedge as a child? Huh? Opening wedge, okay. So we keep the cora on the, the hinge on the lateral cortex, and we do a correction. So you've got a good correction, your axes are well aligned. What happens more often than not, especially, let us say now if your cora was here, then what would you do? And this happens frequently. All the HTOs and all their cora is up there. So now what will you do? So then the usual thing is to do either an opening wedge or a closing wedge, but do it lower down. And you want to be safe. So you say I will be away from the physis because I don't want to injure. Plus you also want some place to fix it. You can't fix into the physis. So you want some space over there where you can fix your fixation. And then you decide to do a closing wedge. Okay. Now if you do a closing wedge, which is the intact portion? This portion. Alright. So you will do your correction and your bone looks well aligned, but what has happened to the axis? It is translated, right. I will extend this further so you can get the ankle actually onto that axis, and we are doing a closing wedge. So now my axis is parallel. You will say, what is the problem? Just do it a little more and your ankle will come on that axis, which is correct. But when you have significant deformities, what happens is, can you see what has happened to the proximal tibia? The angle between the proximal axis and that long one is now how much? 94. And that is normal or abnormal? Abnormal, right. So if it is corrected excessively, you will get a bone which looks straight, but you will have a problem with the joint orientation. You can't make it out now because I can't turn it, but just imagine if this bone is tilted to become straight, then the joint line will become oblique, right. So, what I showed you first is if you can do the osteotomy at the level of the cora. I am cutting it at the level of the cora and I am keeping the hinge over there. I get my axis well aligned. That was a closing wedge. I can also do an opening wedge. So, if the osteotomy is at the level of the cora and the hinge is also at the level of the cora, that is, everything gets corrected perfectly. That's osteotomy rule number 1, which applies 90% of the time. If you have a tibia which is like this, you draw your proximal axis, you draw your distal axis that obviously meets at the level of the obvious deformity. So, if you had a choice, most likely what you would do here is do a nailing. So, you are doing the osteotomy at the level of the cora, and let us say I want to do a opening wedge, which means the hinge will be at the lateral cortex and I open this. So, my deformity is corrected, I just put in a nail, matter is over, right. So, this is osteotomy rule number 1. Now, what if for this case itself, this skin is all very bad, the area of skin in this region where you would normally do the osteotomy is all bad, or it is sclerotic like Divya showed you in the earlier case, and therefore you say no, I can't do the osteotomy through this bad skin, this may have trouble. So, I will do the osteotomy a little lower down through skin which is normal. Okay. So, we then do the osteotomy over there. Now, what do you have? A sort of S-shaped deformity. There is no translation at the bone ends. The bone ends are not translated, but in reality there is translation because the axes are translated. Now, think back to a supracondylar osteotomy. All of you all have done supracondylar osteotomies for varus malunion of a supracondylar fracture. Where does that fracture occur? At what level? Supracondylar humerus? Just kind of at the olecranon fossa, right? That malunites in varus. And then you go and do a closing wedge osteotomy if you want to do the French osteotomy, slightly above. And what is that one line which is sort of written in all the descriptions? It should be as close to the lower end of the humerus as possible. What happens if you are not very close to the original fracture line? What are the common complications of a supracondylar fracture? What? Yeah, say it. Bump. Okay. What is a bump? A bump is exactly this. And nowadays the new descriptions of supracondylar osteotomies that have come in, what do they say? Along with the angulation, what do they talk about? They talk about translation also, right? to reduce that bump. So what is happening over there? If you think about it in deformity terms, the seat of the deformity or the origin of the deformity was at the level of the olecranon fossa. So the cora is at the olecranon fossa. You can't do an osteotomy over there. So you do your osteotomy slightly higher up. Now if you are within a certain range, it doesn't look too bad. But if you go too far away, you get what is known as a Z deformity. Remember the word? This is a Z deformity. In the tibia, in the tibia it is less evident. In the femur though you won't even make out, but in the upper limb you can very clearly make out the Z deformity. So now if I have to correct this Z deformity, what do I have to do? All I have to do is translate this medially. Correct? So now what has happened? There is translation at the fracture site, but if I correct, if I hide this portion, do you see anything abnormal? No. Center of the knee is aligned with the center of the ankle, and you just get a little bit of a bump. So that's that X-ray with the red line which he showed you, that the femur looks like this, but axis is perfectly right. So this is osteotomy rule number 2. So if you are going to fix this now, can you fix this with a nail? You can't fix it with a nail. So you will either have to fix it with something like a plate or a fixator. Now what the fixator does kind of magically is, with a fixator I can keep the hinge at the cora and I can do the osteotomy lower down. So my hinge is at the cora and my osteotomy is lower down. I auto-magically get the angulation as well as the required translation. Right? So my axis is corrected, I have some translation. So this is osteotomy rule number 2, which states that if your hinge is at the right level, even if your osteotomy is above or below, you will get appropriate correction. So does this mean that everywhere you want to do the osteotomy away from the cora, you need to use Ilizarov? No, not necessary. You can, as long as you have planned it. Now you know that to get my axis corrected, I need so many millimeters of translation. So you can look at it on the C-arm and actually get the translation. So that's what on our C-arm pictures, you showed them that, Divya, that we did the translation first. So I'll show you that again. So there what we do is we build in the translation and then do the angulation, so that now the axis is corrected. But if you do it with an Ilizarov, it can happen automatically. Next thing that you have to look at is our cora is there. Now you say, oh okay, now osteotomy rule number 2 has been told, so we can do the osteotomy anywhere, and you say that that skin is so bad that I will do the osteotomy here. Now what do you think will happen? So my axis is corrected, but anatomically this is not possible. I mean, it is possible, you can put on a fixator and get this kind of a construct, but this is not really doable. So what's the difference between this one and the earlier example? Why is the displacement more? Because the osteotomy is further away. So there is a limit to how much you can do the osteotomy further away. So again, if you do the planning, if you do the simulation, you will know that okay, up to here I can do the osteotomy and I will get 50% contact. So I can do the osteotomy up to here and then do the translation. Right? So osteotomy rule number 1 is, if the hinge, and by hinge I don't mean only an elixir of hinge. Whenever you do a opening wedge, whenever you do a closing wedge, the intact side is the hinge, right? But here you will either have to use an elixir or do the correction and then do the translation. So osteotomy rule number 1, hinge and osteotomy at the cora, all is well, 90% of the cases. 10% or maybe 8% of the cases, you will find that you cannot do the osteotomy at the same level. So then you will have to build in translation. So whenever there is an osteotomy which is away from the level of the cora, you will have to have translation, okay? And osteotomy rule number 3, when you say that both the osteotomy as well as the hinge are at a different level. That is what I showed you. Now what is going to happen? There will be a residual translation or a Z effect. So osteotomy rule number 1, hinge as well as osteotomy at the level of cora. Osteotomy rule number 2, hinge at the level of the cora, osteotomy may be above or below. And osteotomy rule number 3 is hinge as well as osteotomy are away from the level of the cora. So osteotomy rule number 3 almost never is utilized. Very rare situations are there where it may be utilized, right? But otherwise it's not it is something to be avoided rather than something to be done. Now where all does this become important? Rule number 2 is not applicable in internal fixation, yes and no, in the sense that in rule number, what happens is when you do internal fixation, in this situation let us say, now you are going to use, you want to use internal fixation here and you want to do a opening wedge. Now you corrected it, if you correct it with an opening wedge, intact lateral cortex, you have got this. So you know that osteotomy rule number 3 is being applied here, but you want to get your correction proper. So you convert this into osteotomy rule number 2, or the other way of looking at it is, you say okay, I am not, at the end of my correction I am going to translate it laterally. So depending on how you look at it, you can say that okay, osteotomy rule 2 is with the hinge over there, so it does not apply. Yes, it is true. Osteotomy rule 3 applies, but you are converting, your knowledge now has told you beforehand that if I do it this way, I am going to have a residual translation. So at the end of my correction, I am going to translate it. Zara switch kar rahe. So in my planning, I already knew that my osteotomy is below the cora, right? So what I did, I completed the osteotomy, then I created the displacement. I didn't correct the angulation. I first did the amount of translation that is required and then corrected the angulation. So I knew beforehand that if I do my osteotomy here, there is going to be translation. So strictly speaking, yes, what you are saying is right, that the rules will perfectly apply in case of when you are using an elixir, but these things are applicable to everything as long as you know what is happening. So that is why a lot of times in pediatric situations, so in pediatric situations, that is the proximal axis, this is the distal axis, and you are worried. So one option of course is to use a fixator and use osteotomy rule number 2. What does osteotomy rule number 2 say? Even if the osteotomy is lower down, the hinge should be at the right level. So, we bring the hinge to the cora and you will find that there is translation, but the axes are fully aligned, and this portion heals up, and with remodeling you cannot see the translation in a couple of years. But let us say you are not comfortable with the use of the Ilizarov, and you say, I am going to use internal fixation. But now I know that these osteotomy rules are there and my osteotomy should be at the level of the cora, but I do not want to take any chance with the epiphysis. So, you will do the planning, and with the planning you will plan for, let us say, a closing wedge with the hinge at the level of that pin over there. You will correct the deformity, and now you can actually measure the amount of translation that is there. Okay, this don't go with the 18 centimeters because this is not calibrated, but you can on a X-ray you can measure that now I need to translate this. So, you will do your closing wedge, you will then do the amount of translation that is required, and you will fix this internally. So, it is not that you have to use an Ilizarov for each and every case. You can use other modes of fixation also. You should know these three concepts of doing the osteotomy. So, now we have sort of completed the circle. We started drawing lines, we started finding the intersection point of the lines, but what was the reason for finding that intersection point of the lines is to find this. Okay. Now, let me take you to a simpler question, again related to old technology. So, you have this patient who you reduced and put into a plaster. This thing looks reasonably okay. You have a plaster on this leg and you want to do a wedging. How will you do a wedging? No, you never, in wedging a plaster you always do an opening wedge. You cut the plaster half the circumference and open it up. But what you will do there is, you will draw your proximal axis, you will draw your distal axis, and wherever the two axes meet, that is where you will cut the plaster in a semicircle and open it up. So, here the cora is more or less at the fracture, but sometimes if your fracture is translated, what will happen to the cora? It will go more proximal or distal depending on, let us see now. So, now you have this here and the cora is now higher up, it is not at the fracture. So, when you do the wedging, you do not necessarily always do it at the fracture. In this case, I will cut it slightly higher. So, when I then move it, it will correct the angulation as well as the translation, right. So, this is a principle which can be applied to the most simple method of treatment, a plaster, and the most complicated like a 6-axis system, cora and the magnitude. All right. So, now I am going to show you a simple way of simulating how you correct. Okay, now just review or repeat everything that we have kind of learnt, or the terms that we learned today. So, one was the axes, proximal and distal, wherever you go. Now, we have been talking all along because alignment etc. has got the major effect on the lower limb, right, and there these axes are all well defined. But if you want to talk of humerus, right, diaphysis, you can draw the diaphyseal line, proximal and distal. Suppose you are looking at the metaphysis of the humerus, or you are looking at the distal end of the humerus, you can always look at the normal opposite side and then from there get the orientation of the axis. Okay, what is that? What line do they call it? Whose angle? Bauman. What is Bauman's angle? Angle between the correct. So what is Bauman's angle? It is nothing but a joint orientation angle. You take an epiphysis, relative to the epiphysis, the joint is going to be kind of standard in a normal situation. And so if you look at the Bauman's angle on that side, you can recreate the Bauman's angle on this side. So it applies to anything. You want to talk of the radial head, how much is the tilt? You draw this, after a fracture of the radial head, you draw this axis, radial head should be at a particular angle. Look at the normal side. Now on the fracture side, you see it is so much. So how much is the displacement, how much is the angulation? That is it. So proximal and distal axis. In the lower limb, how to derive the proximal and distal axis in the femur and the tibia? What is the importance of the chora where the two axes intersect? And what is the relationship of the chora to deformity correction? For most cases, as I said, the chora is where you will do the osteotomy. We also learned that if you cannot do the osteotomy, or for some reason you do not want to do the osteotomy at the level of the chora, then what you have to do? You have to be careful about the translation that will occur, and you have to correct that translation, right. So now there are two ways that you can do this, the simulation. You take your X-ray, make a tracing, draw all your lines, and then if you are going to cut out a wedge, actually cut it out, close that, do the paper tracing, cut the paper tracing and check what is happening. The other simpler way that and kind of non-destructive way that I prefer is to use what we call OHPs, transparencies, okay. And you all already did this, you all already did this planning. So this is just like a revision. You draw your proximal axis, you draw your distal axis, and now you get the chora, right. And what is the bisector line? It is the bisector of the obtuse angle, right. So we draw the bisector line. So that was, I think, about 150 or so. So we are bisecting that. And then draw the transverse from the convex to the concave side. All right. Now you take a tracing. Let me just see if I can show this full view. And trace out the distal fragment as accurately as possible. Okay, so I am tracing out the tibia as well as the fibula. And I am also putting in the axis. So now on the OHP I have only drawn the distal fragment. Okay. I like to use different colors so that things are clear. Now where should my hinge be? On the bisector line. Okay. So I put a pin there and I am correcting it and checking. So I have now an opening wedge. So even if you don't have any excuse कि सर आपके पास तो कंप्यूटर है, सॉफ्टवेयर है, मेरे पास क्या है, मेरे पास माँ है, तुम्हारे पास OHP भी है. So the same thing if you do with a closing wedge, or if you go further away, you can look at all the scenarios. Now you see I am far away, so the amount of opening that is happening is much more over there. So I am getting a opening wedge as well as lengthening. The further away I take it, the more lengthening I get, but each time my axis is perfectly aligned because my hinge is on the transverse bisector line. Okay. So in a now suppose we do the osteotomy higher up. This is how you can simulate. You want to do the skin is not good over there, you want to do the osteotomy higher up, but if I do it with the hinge still at the cora, translation will happen, but the axis will still be well aligned. So now you know how much translation you need to build in over there. So when you do that, you can translate it by that many millimeters and fix it internally. Whereas osteotomy rule 3, both are at the wrong level, the fracture ends are not, but you get what we showed you just now was the Z deformity, two equal and opposite deformities. So same thing can be used for the I think, do we have that distal femur also after this? We have not done proximal femur, so I won't show that to you right now, we'll do that tomorrow. Distal femur you all did the planning, right? So this is just another, this is 521A. So we draw the proximal axis, we draw the distal axis, this is 90 degrees I know. So my cora is at this level, but I cannot do the cora in the femur even if there is no epiphysis. If it is an adult, you can't do the osteotomy below that level because then you will be intra-articular, right. So if you want to minimize the chance of stiffness etc., your osteotomy will be at that level. So if you do, so same thing, what we are doing now is drawing the distal fragment, drawing the distal axis. So I have already done the planning on the paper, now I am just sort of transferring the osteotomy and the distal fragment onto the OHP. All right. So now we are doing the bisector line. Which bisects the obtuse angle. That is what is where I can put my hinges. Normally when we are doing just an opening wedge, the hinge is on the convex cortex, right. It does not have to go very far away. So now my osteotomy is above, but my hinge is at the right level. So I am getting this translation here, but the axes are perfectly aligned. If I do it further away, I will get that much lengthening. Of course, with internal fixation etc., this is not an option. If you do it at the, if you just do an opening wedge, osteotomy and hinge at the wrong level, you get a translation of the axis. So now if you want to correct this, I already showed you that the further away the osteotomy is from the cora, the more is the displacement. So now if the osteotomy with the osteotomy higher up, there is a significant amount of displacement. So generally we try to keep the osteotomy as close to the cora as possible. And if we do the wrong thing, now look at this, all of you all will have seen this shape in distal end femur fractures that you have fixed, right. This is the golf club deformity. And why does that happen? Because you have not put your DCS or your blade plate parallel to the joint. If you put it parallel to the joint, you do not get this deformity. Now suppose you fixed it, or you put your blade plate or you put your DCS, and now you do not know what is to be done. Now you know. What do you have to do? You just have to what? Translate it a little, right. You got this deformity, all you have to do is translate it a little laterally and everything will be set right. So this is the reason why you get a golf club. But if you do the same thing, with the cora at the right level, you have a little bit of translation, but the overall appearance of the femur looks normal. When you do a DCS, what do? You are supposed to put your device parallel to the joint, because the device is made in such a way that it should be parallel to the joint. Okay. After you put this parallel to the joint, then you fix your plate to the bone. Now if you do not put your device parallel to the joint, then the device, when you push it to the plate, will go either too close, or meaning it will push the distal fragment inside. So your distal fragment then becomes prominent. So now once you know that this is the issue, because the fracture is like an osteotomy, all you have to do is correct that translation. And this is something you can see on the C-arm, that yes, I can see that there is a golf club, and especially if it is not parallel, then you can move it. This also happens with lock plates. If your lock plate was meant to be standing away from the bone and you pull the bone to the lock plate, again same, you pull the bone to the lock plate or push the distal fragment to the other side, the same issue happens. So it's an issue of wrong insertion of your original implant, right. Now there is one more part to this, which is which is the proximal femur, but we have not done the proximal femur as yet. So what I will suggest is you do this because 406 you have already planned. Take an OHP and trace out the distal fragment and see how all the osteotomy rules work. Okay. Then for your homework, you can work on which is that one, 521.